So, good morning, everyone. I don't know whether you hear me well everywhere. I don't know. So, I'm very delighted to be here. I think this is a very important meeting. I always say in any project in life, what matters most is ownership. And one of the examples I always give is, have you ever seen somebody washing a rented car? So, it is good that patients are getting involved in the process of their healing, but it is also great that patient organization getting involved in what we do in healthcare. And I think if you want to have a positive change toward patient-centered care, you need involvement of patient organization. And what I've seen in many countries that normally the patient organizations are involved in the logistics around care of patients in their own country. But there is another involvement that is also very important, is involvement in we as physician adhering to the guidelines, adhering to the evidence that is mostly directly what is the best for the patients and not what is the best for the system of healthcare. So it is very important, and I'm really delighted to be part of this process today. I work as a cardiothoracic surgeon in Maastricht. I'm an academic physician, and what I mean by that, so as an academic physician, I have a mission to advance the field. So I have a research lab of more than 10 PhD students. I'm very involved in education, in innovation, but also trying to be involved in these kind of events to listen to the patients, but also convey what we are doing in the healthcare. These are my disclosures, so I'm involved with many companies, and they're all in light of training of different new technology. This is where I work. It's a Maastricht University Medical Center, which is an integrated medical faculty with a hospital in Netherlands. And if you think of Netherlands, you think of Amsterdam, which is here, but Maastricht is here. And as you see, the region of Maastricht is like an appendix. And it's a very interesting region because so you have Belgium, and you know as Belgium has 3 official languages. The Flemish, which is Dutch, in principle with a different accent, the French-speaking, the German-speaking, and then you have Germany. So it is also reflected, but more than 50% of people working in Maastricht, they live in different countries, like me. I live in Belgium, but I work in Maastricht, and you think, but it's only 10 kilometers from the hospital. The content of the presentation, the first presentation will be, I just want to give you an idea about the share of the pathology, cardiovascular pathology, and burden of the disease and mortality globally. Then there will be a section I was not sure about whether to include it, some sort of high school slides about why cardiovascular system, because if you understand that, you understand the function of the heart valves, it is much easier to understand the pathologies. And then I will touch on the importance and criteria of assessing different pathologies. Every 20 years is a manuscript published in Lancet, and the Lancet and New England Journal of Medicine are 2 very prestigious journals, medical journals. and it is about the global burden of disease and risk factors. This is one published in 2006, but actually it's not really changed much ever since. So you see around 56 million people die annually. The most common diseases are non-communicable diseases. Obviously, during COVID, that changed a little bit. Over 10 million children die annually. And undernutrition was the leading cause in the previous report, as in 2001, and still is one of the major causes of death globally. If you look at the leading causes of death globally, you see the ischemic heart disease, which is a coronary disease, is the first cause of the most prominent cause of death. Cerebrovascular disease, and if you look at the projections 2019 and 2021 still, and is projected also in 2050, still cardiovascular disease will be the most common cause of mortality and death. If you look at the risk factors, because you talk about diseases that leads to death, but what are the causes that leads to those pathologies? There are many causes, but eventually you can actually summarize this in three major causes: smoking, undernutrition, and what I call, I don't know whether that is even an English word, overnutrition, abundancy. So over 1 billion people live with undernutrition, and over 1 billion people live with the causes of overnutrition, which is obesity and so on. If you look at last 20, 30 years, what we did in cardiac surgery, for example, about 80% of our operations, interventions, were coronary disease. Now that is moving because obviously with advances of PCI, about 40 to 50% what we do in clinical practice operations are coronary disease. So the rest is valvular heart disease. So why cardiovascular system? So if you think about the smallest building block of life, which is a cell, and we define life as some attributions of having the ability to grow, move, reproduce, and metabolism. And you have to consider that metabolism is something that actually sustains growth, move, and reproduction. And the metabolism, you need nutrition, and you need to be able to give your waste away. So that all happens towards the surface of a cell. So life, every process that we define as life is in the cell. Now, if you consider that for simplification, a cubic, and if it becomes bigger and bigger, the volume increases exponentially, and there is a problem of that we call a problem of surface, because you need a surface to sustain life. That's also the reason that the surface of the lungs are as large as a tennis court. The surface of the bowels are as large as almost 2 tennis courts. So this is very important. That's why the cells are small as they are. Now, if you go to the multicellular organisms, and if you bring all those cells together, there is a problem still how you could sustain the metabolism. And this is a flat form without cardiovascular system, and the whole concept works because of the process we call diffusion. So during the evolution, somehow there is a creation of heart chambers and valves, and you see how bigger the animal is, how complex it's become. And very simple here. So if you have a pump without any valves, the pump will pump forward and backward, which is not really efficient. So that's why you have the valves that direct the flow in one direction. And somehow in evolution, it was more efficient for the cardiovascular system to have two chambers. You have to consider that the heart is composed of two pumps in a series, the right pump, the left pump, and every pump has a collection chamber of blood and the actual pump. So the atrium and the ventricle. And ventricle is actually the actual pump. And each ventricle has an entrance valve, and the left side is mitral, and an exit valve, which is at the left side is the aortic valve. So if you look at this graph, you see the blue is the right side of the heart, and the red is the left side of the heart. So each side is composed of a collection chamber, which is the atrium, and the actual pump, the ventricles. And each ventricle has an entry valve. At the right side is a tricuspid, and the left side is a mitral, and each side has an exit valve, aorta and pulmonary valve. So curiously, so you know that the most common pathologies happen at the left side of the heart. Why is that? Why do you think? Sorry?
The left side works more than the right.
Why? Because obviously the surface of the whole body is much larger, so the pressures on the left side are much higher. So that is the reason that most valvular heart diseases happen at the valves at the left side. And all the valvular heart diseases that happen at the right side predominantly happen because they are associated with what happens on the left side. Obviously, at the left side of the heart pumps blood through the aorta into the aortic valve to the aorta. And the aorta obviously gives blood and everything. That's why if you have a problem at the left side of the heart, you will have an effect on every organ if you progress through heart failure. Yeah, of course.
Is it the same female as male? And this different female?
The physiology is the same. The physiology is obviously the effect. What we see that you see more valvular heart disease in men, but that is a different issue. The physiology is the same. What is also important is to understand that the valves of the heart are not to just close when they need to close, but it's also important that they have to open when they have to open. So if I operate a patient and look at the aortic valve, normally the aortic valve is composed of 3 cusps, which are almost translucent. Why? Because when the heart contracts, the valve shouldn't give any obstruction, any resistance to blood flow. So as much as the function of the valves are to open and close, there are 2 different things that they have to, the function of the valve is very important, both opening and closing. So there are 3 most common pathologies that happen in the cardiovascular system. One is ischemia, caused by atherosclerosis, as you know. The other is a valve stenosis and a valve leakage. Obviously, the process of atherosclerosis is not the subject of, of this lecture, but just very briefly, this is a process that leads to blockage of the blood vessels, and is important because once an infarction happens in a heart, and you don't have a good function of the wall of the heart, it affects the valves of the heart as well. So I'm mentioning this because around 40% of patients, for example, with mitral regurgitation, the cause is functional, and functional meaning that the problem is not the valve itself, but the ventricle. So what are the diseases at the valvular level? One is a stenosis. So, and the most common is rheumatic valve disease. We don't see it in Europe. You see it still in other parts of the world. Congenital, for example, bicuspid valve, aortic valve is the most common congenital pathology. And congenital pathology is important because you have a different anatomy, and those patients with a congenital anomaly of heart valves, they are more susceptible to pathologies of stenosis or leakage. And then you have the valve leakage regurgitation, because stenosis obviously always happened gradually, but leakage can happen very acutely or a chronic regurgitation, so progressively. It's important because when you have an infection of the heart valve and your valve is destroyed and doesn't function well, so your heart haven't had any chance to adapt itself to the leakage. So the consequences are much severe. Yeah, endocarditis, yeah. In general population, the prevalence of clinically significant heart valve disease is around 2.5%. If you get older, the prevalence can be as high as 13%. And for those aged 75 and older, it even increased to 15%. So what happens when the valve gets stenotic and when the valve leaks? So as indicated before, there are two processes that are very important, what we call pressure overload and volume overload. So if you think about the left ventricle, aortic valve, becoming stenotic, what does it mean for your heart? It means that the heart needs to build higher pressures to pump the same amount of blood. So what happens? The muscles become thicker. And that is what we call pressure overload, because of the pressure overload. You get a concentric hypertrophy. When the valve leaks, is a different process. So think about the mitral valve, which is the entrance valve of the heart. So it has to open when the heart fills, and it has to close when the heart pumps forward into the aorta. So if the mitral valve leaks, what happens? Every time the heart needs to pump, it doesn't pump fully empty. And the heart gets continuously blood from the lungs, the left side. So the left side undergoes a volume overload. So what happens? To compensate, you get eccentric hypertrophy. So the heart muscle, the heart becomes larger, but the muscle becomes thinner. And that is actually what leads to heart failure. So again, there's an example of the valve stenosis, which is a progressive process. You get calcification of the leaflets become stiff, thickened, fuse with each other, so the opening becomes narrower, and this leads to hypertrophy. And for a very long time, patients have no symptoms. And once the symptoms come in, that becomes very dangerous. So what are the symptoms of patient with aortic stenosis? For a very long time asymptomatic, but everything what happens, you can also understand because of pathophysiology. Pain. Why? Because the muscle becomes thicker, the blood vessels, they don't grow with the muscles, because so the muscle needs more blood, so the heart works harder and more oxygen consumption, so pain. So dyspnea. Syncope. So as you know, the heart pumps blood into the aorta, and the first organ getting blood is the brain. So you can imagine when the heart at some point fails to pump forward adequately, and you get syncope. It can be one of the first signs of aortic stenosis. And obviously if you don't do anything, the patients, they go in heart failure. So for the mitral valve, it's a bit more complex, because mitral valve itself is deep into the heart, the entrance valve of the left side. And the valve is composed of two leaflets, and they are attached with the cords, what we call chordae tendineae, to the papillary muscles. And why is that? Because every time the heart contracts, if there wouldn't be any cords, you get actually a floppy situation and the valve will leak. So the function of the mitral valve depends also on the muscle, obviously. If you get an infarction, and an infarction leads to a floppy part of the region of the muscle, so you get displacement of the papillary muscle, so you get a change of geometry, so the valve doesn't close very well, so you get leakage as well. The most common pathology is a leakage of the valve. This is an echo, transesophageal echo, when you see actually these two valves, they are not really coapting, but one overrides the other, as you see here in the cartoon, and you get a leakage. As indicated before, so if you have a significant leakage at the left side of the heart, you get volume overload. The volume overload leads to dilatation, so the heart chamber becomes bigger, so the muscle grows thinner, and you get, at some point you get symptoms. And what are those symptoms? Tiredness and fatigue, because if the heart muscle becomes thinner, the contractility decreases, so it means, you cannot do things that you're used to do before. Shortness of breath, because the left side of the heart gets blood from the lungs. So if you have a volume overload, so you cannot pump everything forward, what happens? You get some congestion in the lungs, and that leads to shortness of breath. You get the rhythm disturbances. Why is that? Because one of the things that happens with volume overload, the heart becomes bigger, the chambers, especially the atrium first, the collecting chamber, and then the ventricle. And that leads to the what we call atrial fibrillation. hospital admission. Sometimes patients have a significant mitral regurgitation, they have no symptoms, and suddenly they are hospitalized because of lung edema. So that can happen. And obviously heart failure. So if you don't do anything, no intervention, at the end that leads to heart failure. So why is it important? Because, you know, if you have a severe mitral regurgitation, you see for a very long time, it becomes almost asymptomatic. And once the symptoms occur, the survival decrease substantially. Actually, mitral valve disease is one of the few diseases that when you intervene at the right time, the patient will have the same quality of life and life expectancy as somebody who has never had any heart disease. I mean, if you repair the valve, a durable repair. So why is it important? Because, you raise a very important question. If you look at the data, and this is actually from 2007, almost 20 years ago, and there was a study published based on a survey, 92 centers in 25 countries. And 49% of patients with severe symptomatic mitral regurgitation that were not referred for any intervention. And you think, okay, this was in 2007. This is published just a few years ago by a French group, and is based on over 100,000 patients. These are based on the 2 years hospitalization in France of patients with mitral regurgitation. So they are symptomatic, severe, and only 8% were sent for intervention. And for mitral, it is also important to distinguish between what we call a primary, which is degenerative mitral regurgitation. So the problem is the valve itself because a cord ruptured. So it is a mechanical problem that you can fix, and a functional mitral regurgitation, which is actually the valve apparatus is normal, but what the problem is the ventricle. So a patient has an infarction. Because of that, you get a enlargement of the ventricle, and because of that, you get a mitral regurgitation. So it is secondary mitral regurgitation, functional. And in functional mitral regurgitation, obviously, is a different ballgame, and you would think, but the majority, almost 70% of those patients had a primary mitral regurgitation. I think, sorry. And why is that important? Because look at here. This is 1 year mortality or all cause of readmission. Almost 70%. And why is that so difficult? Obviously, there are 3 things: identify, define, and assess. And the first thing is identification. So you can have an asymptomatic mitral regurgitation for many years, but you don't know it. Your physician doesn't know it. And at some point you get symptoms, and then you are referred to a physician. So there's lots of work to do at this level. Second is, obviously, there is a problem which is detected. You need to define what it is. And for that, you need to expertise, obviously. We'll come to that in my second talk, because that is not so simple. You don't have the expertise everywhere. Um, and then you have to assess it. And assessing actually different heart valve disease is not just a parameter. It's not just you look at the echo of a patient, you see a leakage, and you say, this is a significant. You need to be able to quantify different parameters that give you an idea, is there a significant volume overload with regard to the regurgitation or leakage, or is there a significant signs of pressure overload? So when we evaluate patients with heart valve disease, obviously we want to know what is the mechanism, because if you have a mechanical problem, then the solution is simple, because you know that you need to fix a mechanical problem. Obviously, you need to think about severity. And why is that important? Because any intervention you do in medicine, it has a risk. So why is the severity important? Because the risk of intervention should be always much lower than the risk of saying, doesn't matter, you can live with this kind of disease. And this comes, as indicated before, it is not just looking at the echo, quantifying this is severe, but having the evidence that it impacts the heart and we have to do something about that. And for that, you need to work in a multidisciplinary team, an imaging expert, somebody who has knowledge and expertise of intervention, surgery, and we consider various factors. I mean, if the patient is symptomatic, what is the condition at the valvular level? What is the condition of the patient? So this is a very complex process, and I'm sure that in following talks, if we talk about the guidelines, if we talk about how to address the asymptomatic patients, and also when I will talk about different kind of treatment modalities that exist, we need to consider all of that. And the example of that is, suppose that you have a simple valve disease, a mechanical problem like a prolapse of the mitral valve, so leakage. And if you look at the echo, you think this is the most simple pathology that you can have, and everybody could fix it. But then the question is not that whether you need to do surgery or a TEER, but from which procedure will the patient benefit? And for which patient of having benefit of a procedure, it depends on many factors. Because if you are 80 years old, it is all about quality of life than durability of something, than if you are 40 years old. So these questions are questions that are very important, and you can only make an informed decision if you consider the patient's preferences, but also you make decisions with the whole team. So these are just to give you an idea, if you consider a patient asymptomatic or symptomatic for any valve disease, we use these kind of guidelines. So we look at quantitative measurements. So it is not just based on preference, but still there are some gray zones that you can go both ways, transcatheter or surgery or medication. So as indicated before, the most important central questions: what is the severity, etiology, mechanism? Do we need to intervene? And then in the case of intervention, for which therapies is the patient most suitable and would benefit, these are two very important questions that only can be answered in a dedicated heart team, where you are working with different experts. They have expertise on the disease, but different skill sets. So if you go to a surgeon and the surgeon should only decide surgery, with the cardiologist decide for transcatheter, but in a team you are more prone to think about what are the solutions, best solutions for this individual patient.